We're going into the innovation panel. The other thing about Dr. St. Goar is he is a very strong proponent for cardiac imaging, and he's been championing it for years. So joining him, we have our advanced cardiac imaging co-leaders. We have Cindy Wang and Alvin Chen. So they have been doing really hard work to bring our level of diagnostic to a world-class level, and taking advantage of the advances in technology, but also, you may hear the MRI right now. That's a brand new MRI. El Camino is investing in very expensive equipment here in imaging, both in Los Gatos and at Mountain View, and it's almost over. Then the cath lab. So anyway, so these doctors are making sure that it's put to wonderful use. So their discussion is to talk about recent innovations and how we apply them here at El Camino. Take it away.
Great. Thank you, Josh. I'm just sort of the dinosaur MC here. But before we get started, let's take a moment. What does the word innovation mean to you? Think for a second. It's kind of an overused. What I would argue, and I'm open for discussion on this, what I would argue is that it's a mindset. It's a mindset of never, ever being satisfied with the status. We can always do better. And I think it's a real privilege to be here where we're living in Silicon Valley. And part of the privilege there is taking on ownership of the responsibility of continuing to do a better and better job. And that's what I personally think is the whole innovation mission that I think we all embrace very aggressively here at El Camino, and I'm actually really honored to be sitting here today with two much smarter than me imagers, and we're going to give a little overview. We're going to go through this quickly and hopefully then get a discussion at the end. So, Cindy, do I turn it over to you?
Yeah.
Do you have control?
Yes, I do. Okay, so in order for us to discuss cardiac imaging, we're going to need to set up some basics so that everyone can understand what cardiologists are trying to evaluate.
Are you in control?
Small, yeah. Okay, there we go. So we're going to go over some basics of cardiac anatomy and function. I'm going to introduce some of you to just the basic testing that we do. And then on top of that, we want to review some of the common applications. Why would your cardiologist send you for this test? And after that, then we will approach the
So we start
common
with
trends.
Cardiology 101, and then we take it up to
Correct.
202 and 303. Great.
Exactly. And then we're going to review some patient cases that would be kind of applicable, stories that you might hear from other friends and family. So I will start off just by doing a very brief anatomy review. One of the major things we're trying to evaluate is the coronary arteries, which are small blood vessels on the surface of the heart muscle. There's a diagram on the right to show you there's a right coronary system and then a left coronary system. The left one is what you would commonly hear when you may have heard very often, oh, this patient died of a widowmaker lesion. That's the main artery that's in the front of the heart on the left-hand side. And so when doctors are doing testing, we're looking to see is there development of plaque or atherosclerosis in these vessels. The other things we're looking at are the size of your heart, the thickness of the muscle, how do the doors of this house work, which are like the valves in the heart. There are 4 valves specifically: the aortic, the tricuspid, the pulmonic, and the mitral valve. These function kind of to let blood move forward and then also shut to prevent blood from going backwards. So these are all things that we want to look at in our common testing. Alvin, what are some just common modalities that cardiologists are using to assess these things?
Yeah, thanks, Cindy. So in terms of the cardiac imaging modalities, there's 4 main subtypes that we have. So most commonly we do echocardiography, which is ultrasound of the heart using sound waves to better determine the structure and function of the heart, both from the valve standpoint, from the size standpoint, and the function standpoint. That's divided up into what's called transthoracic echocardiogram, which is just your basic surface echo. Many of you may have had a test like that in the doctor's office. We can also expand that to transesophageal echo, which in certain cases we need more detailed imaging of certain valve structures, certain chambers to look for clots and things. That's a more invasive procedure where we put we put an echo probe down your esophagus in the hospital setting to look at things more closely. Then we have nuclear medicine, which is a scan that we use to determine the blood flow to the heart. That's either done with regular myocardial perfusion, and there's also PET scanning that can be done nowadays for that. And then the more advanced imaging modalities, which will be the focus of today's conversation, are cardiac CT and MRI. And those have real tremendous value in determining the blood flow to the heart, as well as any underlying structural abnormalities like scar tissue that we can see with MR imaging. Next slide. And what's interesting about these imaging modalities is almost all of these have both a resting and a stress component to them. So, some of you may have had a stress echocardiogram. That's a procedure where or imaging study where we assess the blood flow to the heart using a non-invasive method, and that can be done either with exercise. Your doctor might want to put you on a treadmill, or it can be done with, if you're not able to use the treadmill, it can be done with a medication called dobutamine, which sort of simulates stress.
Why is stress so important?
Yeah, so it's important because most of the problems that happen with the heart happen under stress. So if you have a blockage of an artery, let's say your LAD vessel is about 70% blocked, at rest it may not cause any problems, but when you get the heart rate higher, you go out for a run or a jog, you start to experience chest discomfort. It's because the demand that's put on the heart by that action, stress, is influenced by the fact that the heart rate's faster, and the blockage then becomes an issue. So that's what we're really looking for with those with the stress modality. Yeah, and similarly with nuclear medicine, we're doing very similar thing, except this time we're just looking at the perfusion of the heart with an imaging study as opposed to using echocardiogram. CT
so nuclear, some people call that unclear medicine.
Yeah.
But specifically there, we have tracers, right? And our heart the muscle is metabolizing, and it's using certain substances, specifically potassium is one of the most common.
Right.
And could you explain a little bit about how the tracer and how that sort of shows healthy versus maybe not healthy heart?
Yeah, so most commonly we're using a tracer called technetium M99, and it's a tracer that under normal circumstances should distribute evenly throughout the heart muscle, and on a scan it'll light up, almost many times actually kind of looks like a donut when we're reading it. For parts of the heart muscle that aren't getting enough blood flow under stress, you'll see a cutout essentially of the donut where part of the heart is not getting enough blood flow. We compare rest and stress to be able to determine whether or not the lack of blood flow is due to an old heart attack, or if it's due to an actual ongoing blockage, and that's what we refer to as ischemia. That may be one term that's come up in some reports that you've seen. So
these are surrogates then for a functional capacity of your heart, would you say?
Exactly, yeah. So they're surrogates, and they're not directly looking at the vessel itself. That actually leads nicely to this technology called CT, or computed tomography, where we actually can look at the vessel directly with three-dimensional imaging. Back in the day, we used to, most patients who had an abnormal stress test, or if we had chest pain that was concerning, would actually end up going to the cath lab for a invasive procedure called a coronary angiogram or a cardiac catheterization. Obviously if you don't need it, it's better to do the non-invasive test first, then go to the invasive. So the CT kind of bridges that gap where you might not want to do an invasive test, expose a patient to the risks of such a procedure, and you do the CT as an intermediate step between the functional testing and the the diagnostic imaging.
And is it possible to get any functional data off a CT?
It is, and we're going to talk about that later.
Yeah. So, I mean, the focus, of our innovation panel is to talk more about CT specifically. So Alvin's going to just review some common CT-related exams and how they're different from each other, or and kind of talk about maybe why your doctor would choose maybe one over the other.
Yeah, so CT, here a couple of examples of some cross sections. It's three-dimensional imaging of the body, but specifically in cardiac CT, we're imaging the heart, of course. And we're able to get these detailed cross-sectional images of the blood vessels and the heart and other associated structures.
I will be talking a little bit about cardiac MRI as well. So similar to how you would get an MRI of maybe your knee or another joint, it is a magnetic field that we place the patient into, and then using essentially magnetic field, we create an image of the heart. And since the heart is a dynamic structure, we'll see essentially movement of the heart on these images. I think I have a video after this. Let's see. Oh.
I think
Might be
it's later.
Later
Yeah.
on. Okay. I'll show that later.
Yeah, so common applications of cardiac CT include both non-contrast and contrast-enhanced versions. So there's something called a coronary calcium score, or CAC score. You can also call it CCS. And what that does is it measures the amount of plaque buildup really in the coronary arteries, which can be a good way to determine how high risk is someone for cardiac disease. So here's an example of someone with really no calcium in their arteries on the left side, and somebody with plaque buildup to a significant degree on the right side. And the important thing to note here is that this is meant to really be just a risk stratification tool. It's not really meant to test for blockage in a patient who's experiencing active chest pain. So this is not usually the test you want.
But this is really a fascinating sort of leap forward in technology, because what is calcium in your arteries? What does that reflect? That reflects the end stage of the plaque process. You build up, you get these soft plaques, cholesterol's in there, you get these fatty lakes, and then they get fibrotic and they finally become calcified. So what we're using it as is a marker. So when someone walks into my office in their 50s or 60s and has a cholesterol that's kind of borderline and says, should I be taking medicine for this? Certainly the first thing I'll always do is a calcium score. Because if they have a 0 calcium score, if they have actually no evidence whatsoever of early plaque, that gives you some time to sort of chill a little bit. On the other hand, and it's not uncommon that you'll see that the calcium score is surprisingly high, especially people who smoke, do have a family history. And that totally changes the dialogue. And then we get really aggressive at pulling out all the stops to optimize their risk factors. So a very valuable tool that certainly everyone should be aware of if they have heart disease. I mean, most of the people like me, I have a pretty high calcium score. I suspect everyone over the age of sort of 65 or 70, but it's clearly a very good early indicator, and so we'll be using it more and more about that. Yeah, thanks, Al.
Definitely, yeah. And I think the other thing to note is I sometimes will say, for a patient who has a calcium score that isn't necessarily all that high, but is high for their age and gender, it's, you'll definitely want to compare with other people in your age group, but it is actually really just the tip of the iceberg. So when you see a calcium score like Dr. Senghor mentioned, it is the end stage. So you could also have all this soft plaque that we're not even seeing on a calcium score, and that's actually where the next CT angiogram comes in. Next slide.
So calcium score is good for prevention, good for probably younger patients, men in their 40s, women in their 50s, younger patients.
Yeah, so CT angiography is really what you need in order to be able to visualize and discuss, degree of blockage. When someone asks me, hey doc, how much blockage do I have? This is really the test that's going to give you the answer to that. And the contrast allows you to visualize the vessels. Actually, I would say these are beautiful images of the three major vessels that we're seeing. And we're able to very well give you a percentage, 50%, 30% narrowing. And this is often a test that we'll do before somebody goes to the cath lab for an invasive procedure like a stent.
Yeah.
Next
And
slide.
we believe what we call hemodynamically significant disease is something over 70% blockage.
Right.
That would be the degree to which you might have symptoms like chest pain, shortness of breath, things like that.
So we give contrast through the IV in order to visualize the blood vessels, chamber sizes, as well as other associated structures like the aorta, and also even looking inside the lungs for potential blood clots. It's a fairly comprehensive test and can rule out quite a bit of different pathology of chest pain, in addition to just the coronary vessels. Sometimes people surprisingly will have something called an aortic dissection, where the wall of the heart, or the wall of the aorta, the big blood vessel that supplies blood to the rest of the body, has a little tear in it, and sometimes we'll also see a blood clot in the lungs as the culprit for chest pain rather than heart artery blockage.
And in terms of the cardiac MRI, so it assesses a few things. One is similar to other tests. We can once again look at the heart muscle thickness, function. It's actually the gold standard for assessing volumes within the heart. We can detect other sorts of heart disease, including other cardiomyopathies, which are diseases of the heart muscle, myocarditis, which is inflammation of the heart muscle, sometimes caused by viruses, and then other congenital heart problems, things that you're born with. And for many people, I guess children who have congenital heart defects, as they age, we can kind of continue to follow them by cardiac MRI. Similar to CT, you can also give contrast, and that allows us to see larger blood vessels like the aorta or pulmonary artery. And then probably the biggest use of it now is to detect if there's any scar tissue within the heart muscle and to quantify that degree of scar. So I think for me, the most common usage in my practice is if a patient has had a heart attack in the past, I can send them for a cardiac MRI. We can see how much scar there is, and then I can give them some prognostic information about, whether or not they need surgery, whether or not we should treat them medically, and kind of tell them what's the condition of their heart.
So the take-home message, there are a lot of different ways of looking inside and seeing the heart, and a lot of different data points that we can utilize to process to get a good idea of where we stand in terms of our heart function and what the issues are, and then most importantly, hopefully alert us to what we need to pay attention to and to take a more aggressive approach to, whether it be your cholesterol, whether it be exercise more because you might have a valve problem that you'll do better with exercise. So we just have this whole plethora of different imaging technologies that we didn't have 20, 25 years ago.
Yeah, definitely. I think I paused this.
Did you do a count of heart flow? Or?
Yes, later. I
We
think
need to keep moving.
after this, yeah. I think this was just a quick image to show what cardiac MRI. This is one of our softwares that we use to quantify. Essentially, the MRI will create slices. It's basically slicing pieces of the heart.
You all know
and
what you're
then-
looking at there? There's a test in a couple of
Yeah,
minutes.
this is the heart in the middle.
This is a snowstorm, and you
yeah.
can take your goggles off.
And basically, we've sliced images through the heart, and we're just measuring the internal size of the heart. You'll see some of these images are what the scar that's there that I talked about. The white part there is the abnormal.
What happens when you
part
do
of the
this and you
tissue.
don't even find a heart in there? Few people we know like that.
Yeah. So yeah, this is just a quick image. We're not going to spend that much time talking about this today. I think we really want to talk about CT and then other technology related to that. So I think Alvin's going to talk about heart flow and about something called CTFFR.
Yeah, so heart flow is, or FFRCT, which stands for fractional flow reserve computed tomography, is essentially an add-on to the CT. So you have to get the CT first, of course, and then what we do at this hospital is we run pretty much every study through heart flow analysis, and this is basically an add-on interpretation of the CT where they use complex computational models to determine what the hemodynamic significance of some of the lesions may be. So let's say you have something that looks a little bit borderline, we call it 60, maybe 70% blocked. It can sometimes be a little bit difficult to tell for sure, whether that's something that needs a stent or needs further procedures. And we'll run the CT through this diagnostic testing in order to better determine whether or not it's something that should go to the cath lab for further evaluation. And I think the next...
So this is an absolutely disruptive, paradigm-shifting technology, because you talk about the structure of the heart and you talk about the function of the heart. What really matters? Well, they actually both matter. And we know that narrowing occurs in vessels, and sometimes that's moderate, sometimes it's severe. But really what matters is the pressure drop across that narrowing. That is the indication of future risk. And this is an amazing story. The heart flow story, when you talk about El Camino Hospital, acting locally but having a global impact, heart flow is a technology that we basically came up with. There was a team, but they came here 18 years ago to El Camino. And at that point, they were looking at big things. And then they transitioned and realized what's really important is pressures and flows in the heart. And there was a brilliant, brilliant scientist from Stanford by the name of Charlie Taylor who realized that actually, if you know what the pressure in the aorta is, if you are able to figure out the architecture of the vessel, you can then do a gazillion mathematical computational equations and figure out what the pressure is beyond the area of measured narrowing. And we already had good invasive data that showed us if it's really significant, if there's a more than 80% pressure drop across the lesion, those are the patients who are going to have really hard problems. So that technology, which started here at Fogarty Institute, Fogarty Innovation up in Sobrato, is now utilized globally. It's extraordinary. And as I say, it is totally revolutionized the whole thought process of what you can learn about a patient without having to do an angiogram. When I started doing cardiology a gazillion years ago, we had one thing we could do. We would do an angiogram. Stress tests aren't worth anything. We know that. Half the time they're positive, half the time they're negative. But what we have now, which is so, as I say, radically different, is we can get so much information about a patient long before we have to bring them into the hospital and do a procedure. And not only that, I can look the patient in the eye and say, you have this narrowing, you have this lesion, it is this long, and I guarantee you, I'm probably going to put a stent in there, and that stent's going to be about this long and this big. A discussion that 25 years ago, we were starting stenting, 20 years ago, we would say, well, I'm going to do an angiogram, and who knows what I'm going to find, and we'll flip the coin, and It is now, as I say, when you talk about improving quality metrics, this has basically changed the whole playing field.
Perfect.
And
Yeah,
you were the first, you did the first heart flow here,
We did
right?
the first
From
heart
what
flow right here at El Camino, something to
Yeah.
be proud of. No, it's I will never forget. It was in the old hospital,
Yeah.
and I had done a CT on a patient, and I had measured the fractional flow reserve with a wire in a patient, and I quietly handed the data to Charlie Taylor and Chris Aarons, who were working on it. And I was in the cath lab 3 or 4 days later, and they walked in and they strutted and said, "We can do it. We got the same numbers with our CT algorithm that you got with your measurement." And I said, "You're going to change the world of cardiology."
Yeah.
Go El Camino.
Yeah.
Yeah.
I think on the next slide we actually have a video from the company themselves.
we're-
Yeah.
We'll
Yeah,
show
we have a video here, and they actually are very kind. They've set up a booth outside. If any of you want to really learn more about it, there's beautiful pictures out there too. So stop by on your way out.
HeartFlow is a personalized medical technology company dedicated to transforming the way cardiovascular disease is managed. Its flagship product, the HeartFlow FFRCT analysis, is the first and only non-invasive technology for coronary artery disease that offers insight on both the extent of a coronary artery narrowing and whether it is impacting blood flow. HeartFlow provides these two pieces of information based on a standard coronary CT scan. From the CT images, HeartFlow creates a complete geometric and physiologic model of the patient's unique coronary anatomy. Next, the scientific principles of computational fluid dynamics are applied to model the complexities of fluid flow. The end result of the HeartFlow analysis is a color-coded map of the coronary arteries, showing the extent to which any narrowings are disrupting blood flow. A physician can use this information to develop a treatment plan that is right for that patient. Previously, only through an invasive procedure could physicians verify if a narrowing in the arteries was impacting blood flow. Now, with HeartFlow, this functional information can be simulated non-invasively. Actively in commercial use, the HeartFlow FFRCT analysis offers the potential to help physicians redefine the diagnosis and management of coronary artery disease.
So the message there is if you go to your physician and say, well, I've got a little pain, blah, 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 and your physician cardiologist says, oh, I think we should rush you off and do an angiogram, what are you going to maybe ask? What about doing a CT angiogram and show me what the heart flow images look like and then convince me that's the right thing to do? Yeah. I'm sorry, Andrew, that doesn't help by El Camino because we should do more angiogram. No, but it's true. And so it's a very powerful tool that you all should be familiar with. And as you're, in the future, if you have any family, friends, or who have cardiovascular issues, it's important to understand the value of it.
So we're going to review a few situations where we might use a coronary CTA specifically. So the first case is a 55-year-old female. She has a history of high blood pressure and high cholesterol, prediabetes. She did notice she had some chest pain and so came to the cardiologist. The chest pain typically happens when she's doing something active. When she rests, it goes away. But it also happens the pattern is, as many patients describe, kind of on and off, depends on the situation. So she does have some family members that have had a history of heart attacks, which has made her concerned about her present symptoms. She's on some blood pressure medication and also cholesterol medication. She doesn't smoke or drink. And her EKG showed a regular rhythm. There were some very, what we call non-specific changes on her EKG. And through decision-making with her cardiologist, they decided to proceed with a coronary CTA. These are what we call straightened images. There's a 3D reconstructed image on the right-hand side. A straightened image, obviously the coronary arteries typically are more curved or follow a different pattern, but the reconstruction of the image kind of straightens it out for you to see if there's areas of plaque. And she ended up having a coronary calcium score of 0, which from what you remember means that she had no signs of having long-term plaque in the arteries. She did have some non-calcified plaque kind of in the middle of the blood vessel in the top, in the left anterior descending artery, but it was more like 40% when we looked at it. So in this case, able to give a lot of reassurance to her. Her calcium score is 0. If we were to do an FFR, in most cases, if the calcium score is 0, it kind of prompts the doctor to decide whether or not they need FFR. We can use FFR both for calcified and non-calcified plaque. And in her case, there's no significant narrowing of the artery. So we can reassure her that her
Absolutely. So this is
symptoms are not
invaluable. That,
cardiac.
we don't have to rush her off and do an angiogram. You're giving her something that's really tangible. On the other hand, there are a few lumps and bumps in her vessels. And if she had a family history of coronary disease and her cholesterol was slightly elevated, or if her hemoglobin A1C or blood sugar measurement was elevated, you would have some really good tangible data here to convince her to be more aggressive in terms of her risk factor management.
Yeah.
Yeah, the flip
absolutely.
side is if this person had just gotten a stress test, like a stress echo, it would have just been read as normal, and people would have said, oh, you're fine, don't worry about it, where in fact she actually probably does need to worry a little bit about that, mild plaque buildup that was found on the angiogram portion, needs
Yeah.
more, aggressive treatment. I saw she was already on cholesterol meds, but
Yeah.
maybe a higher dose.
Yep. So we would probably target a lower LDL cholesterol for her. We'd also encourage her that she has existing plaque, that she should modify her lifestyle more, get more exercise, get better sleep.
Comes back to what we said earlier on.
Yes.
It's optional. The progression of this is optional. If you do those things which these guys are recommending, there's no reason that if you were to repeat this study 5 years from now, it would have changed. But you have to be proactive. You have to be aggressive, and take really thoughtful and disciplined approach to managing your risk factors.
Yes. Now the second case is quite the opposite. Alvin will go over this one.
Yeah, so this is a 48-year-old South Asian male who has high cholesterol, comes in with vague symptoms of epigastric pain, so upper abdominal, and maybe migrating a little bit to the chest area. And similar to the other case, the discomfort would happen, when he's exerting himself. He's fairly active, exercises an hour a day on his Peloton bike. So sometimes it would occur then, but it would also occur randomly without any particular triggers. He's not on any medication. His father did have a stent done in his 50s, so he's getting pretty close to that age and is worried about his own history. And he gets referred for an outpatient stress test. The reading of it comes back to being mildly abnormal, whatever that means, right? So
Equivocal.
He
We
goes,
get a lot of
equivocal,
those.
yeah.
Equivocal.
And he reviews options with his cardiologist, including coronary CTA or invasive angiography. And the patient, understandably is pretty worried about doing an invasive procedure right up front, so we opt for the CT angiogram. And we'll show you some of those images on the next slide. So here is his LAD vessel in cross-section. These are what are called curved reformats, where we can actually see the contouring of the vessel. Looks pretty clean, nothing that stands out as being abnormal. Next slide. His circumflex vessel has minimal plaquing in the proximal portion. I don't know if it's visible here, but there's a little bit of that calcified plaque at the top of the vessel.
See the bright white that kind of.
So this is the vessel that
shows
wraps
up.
around the left side of the heart that comes off
Right.
LAD. So an important vessel.
Yeah, though it doesn't meet, even 30% criteria on this roadmap that's provided by HeartFlow. And then the last vessel, this is where we find the problem, which is, and highlighted in purple there for you nicely, is that there's what they call 70 to 99%. I favor even closer to 99% for that lesion. That dark stuff almost is blocking the entire blood flow. You just see a sliver of contrast coming through. It's not 100% block because you see contrast after that lesion, but it's pretty tight. This is not equivocal at all, unlike the stress test. So he gets sent to the cath lab.
You didn't do a heart flow on it?
This one actually was an inpatient case, so the heart flow didn't.
So the question comes up: why would you waste the time to do a heart flow? Well, actually, it would be very helpful. I mean, this is pretty obvious, but there are sometimes patients which have, the CT overreads it, and that was one of the problems early on when we introduced CT without the heart flow analysis. There was a lot of patients who had these borderline CTs that went off to the cath lab inappropriately. So the number of falsely positives was too high, and that's really changed with heart flow. And that was one of the problems with the early introduction of CT. People say, gosh, it's an easy way just to get to the cath lab. You get a CT, it looks bad, you send it. Now we can actually tell functionally. And you're right, if we sent this off for a heart flow, the top of the vessel would be nice and beautiful and blue, and then the bottom would be probably just shiny bright red, which shows that there's a significant pressure drop across that.
Yeah. So this technology, this one is what we call roadmap, which is kind of like the pre-heart flow. The nice thing about roadmap is some patients have a lot of these yellow areas, and the purple area kind of just pulls out to your eyeball right away that there's if you didn't recognize it on the CT already, it kind of flags it right away. So.
And the other reason, and one of the real powers of HeartFlow here is we can do a procedural planning where we can go in before we get the patient in the cath lab and put in a stent, all computational fluid modeling, on that proximal vessel and see whether or not it changes the pressure across a more distal, and do we need to possibly go in and put in 2 stents. So what it means is a conversation that I can have with my patient and say, gosh, you actually have two areas in your vessel, and I've modeled it out, and so you're probably going to end up with 2 stents, or maybe say no, 1. So it gives you, as I say, a lot more really objective, concrete information to have in your discussion with your patient before you then get in to do something.
Yeah. And if you're interested in this further, they do have models at their table to walk
How are we
through,
doing
and
time-wise?
you'll actually see that FFR change.
1 minute. Okay.
And I
Yeah,
think
so we'll just quickly go through his angiogram films.
yeah, we'll see. This is a correlation.
Yeah, so this is the cath correlation, and this is one of the a still frame image from the cardiac catheterization procedure where the dye is injected directly through the vessel. Actually, if you could go back to the previous one. You'll notice right under the, kind of where that, it's called the
Point it out, 'cause
Yeah,
that's
I
a
don't know
little-
if we can point it out.
Do you have a pointer on
maybe
there?
I'll
There's
just
not
come
a
to
pointer
the.
here. Yeah.
Yeah, point to the screen, because
Yeah,
this
so
is
right
this
here,
is
this is a pretty dramatic example where you see right here, the blood flow. There's a little kind of mild narrowing there, but you see it kind of almost looks like someone took a
Pinched
bite
off.
out of this vessel right here. That's a 99% blockage, and if we were reviewing this in real time, the flow down this vessel was very slow, what we refer to as TIMI 1 or 2 flow. And next slide. What the interventional cardiologist will do is then put a wire down the vessel and inflate a balloon to essentially push the plaque out of the way. And then next slide. And then after that, put a stent in to act as a scaffold to prevent the blockage from closing in again. And you see after the procedure, this is the coronary wire is still in there. The blockage is completely resolved, and the vessel's looking very nice, and the flow down the vessel is normal.
back in action.
Yeah.
Presentation.
Thank you, guys.
So grateful. We're going to have a few question and answers, but it's all about me here. I just want you to know that I had a calcium score this week, and the rad said I should have you take a look at it.
Oh,
So
yeah.
I don't know, I'm a little
No
nervous.
problem.
But anyway, so it's one of the benefits. But anyway, we want to ask some questions of our doctors, and then I'm going to test your knowledge a little bit later. One question.
Question.
Right here with the microphone.
Do you recommend
Do you recommend statins? She asked. Is that's your full question?
based on
Yeah.
high cholesterol
The question was,
and age?
yeah. So we got the question. We got it.
Yeah, so the question is, do you recommend statins? I think statins are the most evidence-based medications that we have to
Balance.
both reduce LDL cholesterol and also take existing plaque to stabilize it. They have multiple uses. Statins obviously have a very bad reputation. I think mostly because it's a very commonly used medication. So there are obviously side effects with any sort of medications that we use. Muscle pain, joint pain, GI side effects. I will say I would say most of my patients tend to tolerate at least a moderate intensity statin. There's obviously other cholesterol medications that are out there. If they don't and they do have muscle pain, then we'll discuss other options.
So, Julia,
Yeah.
great question, especially because statins seem to get bad press. They have totally changed the care of our patients. When I started taking care of patients here at El Camino 35 years ago, on the weekend we'd frequently get 1, 2, 3 heart attacks during the week. They just were, they would come in all the time. And then statins were introduced, and they became basically a vascular vitamin, and they just quieted down the whole process. Now, the good news is, you're right, there are some side effects. We now have a toolbox of other medications, just a
Yes.
whole plethora of different medications, all focused on doing the same thing, which is to get your cholesterol under control, bring it down to a therapeutic level.
Yeah.
Yeah, at
Yeah.
present, there's at least 4 common classes of medications that we use aside from statins that can also lower LDL cholesterol. One thing I will add is with the cardiac imaging portion it can act as a big motivator for people to say, oh, okay, I've got a problem. I actually do need to get my LDL lowering. On the flip side is actually if you do a CT angiogram and you have a 0 calcium score and no non-calcified plaque at all, it's also reasonable in some cases to de-escalate statin therapy as well. So that's kind of the flip side of the coin. I know most doctors are still trying to optimize cardiovascular health, but the flip side of some of that imaging is that sometimes we actually find that you don't have any plaque buildup and maybe you don't actually need to be on a statin, especially if you're getting to 75 or older. The benefit is maybe a little bit less.
Okay, we have a question from our online audience.
Yeah, one question was, is there a limit to the number of heart flow studies that you can have? And does it make any difference if
Once
you
a
have
week.
stents?
And what was that?
Does it make any
You
difference
did a good
if you
job,
have
Sa-
stents?
Oh, does it make a
Once.
difference, heart flow, if you have stents?
Oh.
Yeah,
Yes.
yeah.
Mhm.
Yeah.
Yeah, absolutely. So heart flow actually is not able to be run on patients who have prior stents. And I would say if you've had prior stents, it's worth a conversation with your doctor whether a CT would even be diagnostic, because depending on the size of the stent, it may not be easily visualized on CT, the inside of the stent. That
Yeah,
is.
so the issue is that stent is really dense. It's metal, right? So that changes the whole penetration to see it. That said, heart flow is they're on the brink of basically taking this to the next level, and I think within this next year we're going to be imaging stent patients
yeah.
too, and it'll help. But it's a good question, and you're probably right. If you got a stent, you probably got some real issues.
Right, yeah. It's actually pretty good for imaging bypass grafts, though. So if you've had a bypass, it's actually not a bad test for that, too. We didn't really talk about that, but that's something that it's good
Now we
for.
can tell.
Yeah,
we need
in
to
the interest of time, we're going to move on, but let's thank our panelists.
Thank
It's
you, guys.
wonderful.
Thank you.
Thank you.